Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and we are pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service.
Hi, my name is James Stoller. I'm pleased to serve as the Chief of Education at the Cleveland Clinic, where I'm a lung doctor, and I am delighted to talk to you today about developing healthcare leaders. I will share my slides with you, and in really presenting this topic, I begin with a quote, I think, to which we can all subscribe, that from Nelson Mandela, that education, of course, is the most powerful weapon which you can use to change the world. And so with that in mind, my brief remarks over the next few minutes will cover the following topics. I'll briefly review the need and rationale for great leadership in healthcare. I'll then pivot to talk about leadership competencies in healthcare, and then finish with a brief discussion about experience with leadership development in healthcare, some best practices, and some experience at my institution, the Cleveland Clinic. So 5 key points as to why we need great leadership in healthcare, well known, I suspect, to all of you. Healthcare faces challenges, challenges of delivering the highest quality care in the safest possible manner, doing it in a cost of affordable way, and providing access. And of course, the hidden curriculum in medicine, at least traditionally, better now than years ago, thankfully, is that caregivers, doctors, others may lack leadership and followership skills. This is the work of Don Berwick and colleagues in the Institute for Healthcare Improvement. They remind us about the challenge of population health, the triple aim, as they call it, the need to provide fabulous care to the population, to do it in the bottom left with the highest possible quality, and in the bottom right, to do it with the highest affordability. The other challenge that frames healthcare in the United States is this. This is a slide that compares on the vertical axis the percent of gross domestic product plotted against time on the horizontal axis. And you can see that we in the United States enjoy the somewhat dubious distinction of having the highest percent of GDP allocated to healthcare, which is currently at about 18%. This distinguishes us from all other countries in the world. And while we certainly have pockets of the absolute best healthcare anywhere, I think that we could all agree that it's not uniformly available to citizens of this country, and that's an access challenge. The other framing here is that healthcare, borrowing from the military, is a VUCA world, a volatile, uncertain, complex, and ambiguous environment. And of course, all of us who've lived through the pandemic, I'm a critical care doctor, a pulmonary doctor, we can certainly remember the VUCA nature of the pandemic, which persists even today. The second of these 5 key points is that leadership competencies matter. They matter to organizational performance, and they can be developed. These are some data from Dr. Tate Shanafelt, then at the Mayo Clinic, now at Stanford, in which he assessed on the vertical axis a leadership score and plotted that against individual satisfaction at the Mayo Clinic within their department. And you can see there is a tight correlation between leadership on the vertical axis and satisfaction on the horizontal axis, such that the rating of one's department leader accounted for 47% of the variance in institutional satisfaction and clearly contributes to burnout, so that leadership matters. The third is that leadership competencies differ from the skills that make us great doctors, nurses, scientists. They are fundamentally different attributes, and I would argue, again, in the traditional curriculum in healthcare, hidden curriculum, that some of the hidden curriculum is actually antithetical to great leadership. We're trained as heroic lone healers, quoting my colleague Tom Lee, and yet medicine is a team sport, so that these competencies differ. They're not taught in most medical school or training curricula, hence the need to pay attention to this at some point. And of course, the process of becoming a healthcare provider, doctor, nurse, scientist, is very time and attention intensive, such that it often eclipses any attention we can give to developing leadership. So with that said, I'd like to briefly review some leadership models. And I show you this image of convergence because there are many models of leadership. I'll discuss just a few. But in my experience, they converge on certain core truths, much like a good statistical model, which converges on some core findings. This is a very selected list of leadership models that by Kouzes and Posner, our 16th president, Abraham Lincoln, opined on leadership, and it's striking to me how similar comments from Lincoln were with those findings from Kouzes and Posner 100 years later. Heifetz's work on technical and adaptive leadership, Collins' work on level 5 leadership, our own work on virtue-based leadership that I'll briefly review, and then of course at my institution we have a very robust and rigorous leadership model that I'll share with you as well. So a nod to the 7 classic virtues. These are trust, compassion, courage, justice, wisdom, temperance, and hope. These are age-old, have been articulated since Aristotle and before. And the notion here is that the aspiration to these classic virtues creates character. This is where integrity comes from. And so we recognize that great thinkers through time, Lao Tse in the 16th century BCE, Heraclitus, Confucius, Aristotle, Plutarch, all have articulated support for the idea that character and virtues matter. Aristotle's quote, "Excellence is not an act, but a habit." Confucius, wisdom, compassion, and courage are the 3 universally recognized moral qualities of humans. These are age-old respected principles. Our work is focused on the 7 classic virtues as drivers of organizational performance. And the notion is that when leaders create cultures that are anchored in these 7 classic virtues, listed again on the columns of the Parthenon-looking structure on the top right, that when leaders create cultures and have a common language around the virtues, that releases discretionary effort in the organization. That is to say, people will do the right thing when no one is watching. And this is a very effective alternative to a carrot and stick compliance approach to performance. The buzzword is when you get better at who you are, when you aspire to the virtues, and of course, none of us is perfect at this. This is not about sainthood. This is about aspiration. When you get better at who you are, you get better at what you do. And I'll bring to your attention a website in which we summarize this for those of you who are interested. At my own institution, the Cleveland Clinic, where we have 1-year appointments on faculty, leaders are evaluated on these 4 pillars: the ability to lead change, to drive results, to inspire and coach, and to connect teams. These are all critical leadership competencies in healthcare. Now, let me pivot to the competencies to lead in healthcare, having briefly discussed generic leadership competencies. And here we recognize the difference on the left between threshold competencies and on the right, differentiating competencies. What are those? Threshold competencies are the criteria that bring you to candidacy for leadership, often involving the clinical respectability and prowess that you demonstrate to your colleagues, or your scientific stature, your academic metrics, etc. These are, if we could consider them necessary, but not sufficient conditions to lead. The conditions, the criteria that will result in your being appointed to leadership and sustained in leadership are the differentiating competencies listed on the right that I'll very briefly review in the next few slides. These are largely technical knowledge, not of your clinical discipline, but of healthcare. The ability to understand the regulatory and legislative environment, being a problem solver, being a lifelong learner and having, in Carol Dweck's work, a growth mindset, and of course, being emotionally intelligent. So if we pivot to each of these, again, having done a needs assessment for our own work, developing courses in leadership development at the Cleveland Clinic, we recognize that healthcare leaders need to know something about operations, something about finance and accounting. Don't need to be a CPA or have an MBA, but you need to understand income statements and so on. Need to know something about IT and systems, need to know something about human resources, including the importance of engagement, belonging, diversity, equity, and inclusion. Be a strategic planner, understand policy. Need to know something about how we're paid, the regulatory environment. As the Chief of Education at the Cleveland Clinic, I need to understand the criteria by which we're evaluated by the various regulatory bodies, the Accreditation Council for Graduate Medical Education, the Accreditation Council for Continuing Medical Education, the Liaison Committee for Medical Education, etc. I need to know something about quality, assessment, patient safety, and management. Need to be a problem solver. We as clinicians and scientists are intrinsically problem solvers, but in that context need to understand how to lead change. Need to be able to communicate in all forums, at the podium, but more importantly, perhaps in negotiation, one-on-one, and in conflict resolution, being hard on issues and soft on people. Need to be a lifelong learner. Goes without saying, this is what we aspire to as scientists and clinicians. But again, having a growth mindset, the idea that through deliberate practice, we can master a challenge. And of course, being emotionally intelligent. And here, this is in some ways the anchor of healthcare leadership competencies, in my view. There are many models, Peter Salavy's work at Yale, Baron's work. We tend to use the work of Goldman, Boyatzis, and others. And they define emotional intelligence as shown here, taken verbatim from their work. The capacity to understand your own and others' emotions and to motivate and develop yourself and others, not in service of kumbaya. Kumbaya is a wonderful byproduct, if you will, of an emotionally intelligent environment. But emotional intelligence is anchored in enhanced organizational effectiveness and high performance. And like many models in organizational development, it has 4 quadrants. Being emotionally intelligent means understanding yourself, managing yourself, understanding others, and managing your relationship with others, again, in service of enhanced performance. If we look at the full Goldman model, you see the 4 quadrants: top left, self-awareness; bottom left, self-management; top right, social awareness; bottom right, relationship management. And then within each, the component competencies, like being emotionally self-aware, being self-confident, and the bottom left, being achievement-oriented, being optimistic. Remember that we as clinicians are often trained in what I call a deficit-based mode. We're used to seeing patients who present to us with signs and symptoms of problems. And of course, clinical diagnostic reasoning allows us to develop a differential diagnosis. The more seasoned you are as a clinician, the more facile you are in developing a differential diagnosis and navigating it to the etiology of the patient's condition. And while that line of reasoning, a deficit-based line of reasoning, works fabulously for clinical practice, organizational thinkers would remind us that it is an ineffective way of thinking of organizations. Organizations are not a compilation of problems. We should be thinking appreciatively or optimistically. This comes from the positive psychology work of Seligman and many others. On the top right, social awareness, being empathic, understanding how our organizations work and being service-oriented. And of course, in the bottom right, being relationship-oriented, developing others, understanding how to manage change, manage conflict, develop teams, much as the pillars in the Cleveland Clinic model that I shared with you earlier. It turns out that emotional intelligence can be learned. Of course, some of us are natively better at this than others, but the data from my colleague at the Weatherhead School of Management, Richard Boyasis and others, clearly shows through serial 360 feedback instruments that emotional intelligence can be learned. These are increments in yellow and blue respectively from baseline, which is 0, in self-awareness and management in yellow and social awareness and relationship management in blue among MBA students at the Weatherhead School of Management, which persisted out to at least 7 years. And so emotional intelligence can be learned. Now, there's lots of evidence that it matters in healthcare. This is a paper by Dines and colleagues who surveyed nurses and fellows about the attributes of the best bedside ICU clinician. And you can see that those attributes highlighted in yellow, humility, team building, respect for others, are not clinical competencies. These are emotional intelligence competencies. Similarly, when chairs of academic psychiatry departments were polled about the attributes associated with their success, again in yellow, you can see the attributes that are emotional intelligence attributes. Inspiring, leading by example, integrity, as opposed to the biggest CV or the best psychopharmacologist. And finally, when Lobus, and this is taken verbatim from their work, when Lobus interviewed chairs of internal medicine departments in academic medical centers, you can see that the synthesis of the findings was that emotional intelligence and its concomitant skills were deemed the most essential competencies for leaders to succeed in academic institutions. So there is a plethora of information that supports the importance of emotional intelligence. Now, a few lessons from industry. Industry has generally been way ahead of healthcare in committing to leadership development. Perhaps the earliest was General Electric in 1956. They developed a campus called Crotonville, where GE employees in the prior eras would go and learn team building, emotional intelligence, etc. But these logos of various other organizations all have deep investments in leadership development in service of enhanced organizational performance. Now, the elements of developing leaders have been summarized by colleagues at the Center for Creative Leadership in North Carolina. And here you can see that developing leaders has 3 elements. It's said that 10% of that is curriculum. In other words, developing a formal teaching around leadership competencies. 20% is relationship-based, particularly through psychologically safe and supportive mentors and coaches. And of course, the vast majority of leadership development is experiential. That is to say, being invited to serve in leadership roles, performing well, and leveraging that experience in service of greater and greater scopes of responsibility. And so finally, a few comments about the experience with healthcare leadership development. First of all, this survey of hospitals, now about 7 years old, suggests that leadership development is relatively uncommon among hospitals and academic medical centers. This survey of the American Hospital Association database suggested, as you can see, that only 1/3 of institutions that were polled offered leadership development. And so there's an opportunity here within healthcare. In terms of best practices, this is a meta-analysis published by Lyons and colleagues in which they looked at various studies, both from the United States and from the United Kingdom, and looked at the best aspects of leadership development programs. You can see that the attributes that were associated with the highest effectiveness were having a mixed faculty. That is to say, some internal faculty, some external faculty. Addressing an interprofessional audience, physicians, nurses, allied health providers, administrators, all together. Using project-based work, that is to say, having teams within the course imagine and then develop ideas in service of innovating in the organization. And then, of course, mentorship, which is so critical to all of our careers. And so modeling that behavior, we at the Cleveland Clinic have been deeply committed to leadership development for decades now. And of course, the rationale was that we believe significantly that leadership competencies matter and that one has to develop a pipeline of capable leaders in service of the organization's success. And so this prompted a commitment to develop curricula for leadership and offer leadership development courses that align with the shared competencies, as shown again in the bottom right, of leadership at the organization. And so this is just a snapshot of the array of leadership development opportunities at the Cleveland Clinic. Going back to almost 25 years now, a course that I was privileged to design and deliver called Leading in Healthcare, which then gave rise to our current Mandel Global Leadership and Learning Institute. We offer and have for now 17 years a 2-day course for all our chief residents on leadership competencies. We have a number of critical academic partnerships in which individuals can achieve graduate degrees. We have offered an external-facing Samson Global Leadership Academy, and we're one of only a handful of organizations that offers an ACGME sponsored and approved novel fellowship in health administration leadership management. And so just a snapshot of outcomes from these various offerings. Our Leading in Healthcare course was delivered over 10 full days, was conceived as an innovation incubator. Every course attendee would bring an idea that he or she would want to innovate in the organization. Teams were formed to work on those ideas, and the capstone experience was a presentation of those fully developed business plans to the leadership of the organization. And it turns out that 61% of those leadership of those business plans, of those ideas, were in fact implemented. They were either implemented or they were sidelined because the team itself thought it wasn't quite as appealing on further detailed review as it was on first blush. Furthermore, this course became a leadership pipeline. You can see that over a decade after course attendance, 43% of the attendees in that course were promoted to a priori defined leadership roles at the Cleveland Clinic, and 18% of those individuals were promoted twice. We believe strongly, and there are data to support the idea that developing leaders is both a recruitment and a retention strategy. Individuals need to grow, and organizations need to provide pathways for their ongoing development. A brief summary of our work in the Chief Residence Leadership course that I mentioned before. We've done this now for 17 years. When we polled the residents themselves, you can see that 95% reported using the concepts during their chief residency. But more importantly, when we polled the program directors of the programs in which the chief residents served, all of them reported observing growth over the course of the chief residency in their chiefs. Now, whether this was attributed to the course is, of course, uncertain. But nonetheless, having growth in their skills and leadership, critically important to organizational success. Finally, particularly pre-pandemic and slowly coming back post-pandemic, we have offered the Samson Global Leadership Academy, which has invited emerging leaders from all over the globe to come and spend time in a curriculum on leadership and organizational performance. And you can see that when surveyed, these senior leaders from organizations around the globe almost uniformly reported that this experience contributed to their growth. So I would summarize by suggesting that leadership is important, that developing healthcare leaders is important, particularly in organizations such as the Cleveland Clinic that are led by physicians, because caregivers usually have not received leadership education. Offering leadership development training is important. That leadership development programs are, in fact, signature features of leading companies. And this was the rationale at the Cleveland Clinic now many years ago to undergird our commitment to developing leadership development courses and offerings for caregivers at the Cleveland Clinic. Finally, our experience with leadership development has been very favorable. And I'll remind all of us that emotional intelligence is a core competency to lead in healthcare and is an alternative to the hidden curriculum. So with that, I'm very appreciative of the opportunity to engage with you and look forward to conversation. Thank you very much.
Thank you so much, Dr. Stoller. I'm Monica Robbins. I'm the senior health correspondent at WKYC TV, and I'm thrilled to be here as your moderator to ask your questions. We have plenty, Dr. Stoller, so I want to start with this one. When should leadership development begin in the career of healthcare providers? Should it be early on in their training, or in the middle, or at the end?
Well, the answer is all of the above, right? We often think of this as a spiral curriculum. so that we, in fact, teach our students at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve, we teach them leadership competencies about teamwork on day one. And then as doctors evolve through their careers through residency and fellowship, I mentioned our chief residence course, that's directed at a slightly more senior level. And then, of course, for faculty or staff, as we call it at the Cleveland Clinic, there's a robust commitment to their own leadership development. Now, the competencies that we focus on may vary over time in terms of where one is in one's career, but the commitment to leadership development is uniform, and it should begin very early and continue.
Is the curriculum the same for early students as it is established for healthcare providers?
No, it differs. And if we think about that through the lens of the emotional intelligence quadrants, right, self-awareness, self-management, these are often much more important to beginning medical students than they are to individuals more senior in their career when they engage in an organization. And at that point in one's career, issues about relationship management become far more important. So the curriculum for medical students focuses on the top left quadrant, and the curriculum for more senior people usually on the bottom right quadrant of the emotional intelligence model.
Would you like to see medical schools actually teaching more leadership type qualities, in their curriculum?
Yes, I think it's a matter of both selecting students on their leadership attributes. We certainly do pay great attention to that at the Cleveland Clinic Lerner College of Medicine, where we're teaching in teams. It's a rather novel curriculum, no exams, no grades. The students are learning as teams and problem-based learning. And so being a team player is very important to one's success in that environment. And so picking students that are predisposed to that and then cultivating those attributes is very important educationally.
You stressed that emotional intelligence was one of the most important competencies to have when you're getting into this, and the general public would think empathy is critical to even think of becoming a physician or a healthcare provider. But what other essential competencies do you need to have to lead in healthcare?
Sure. Well, the beauty of emotional intelligence, Monica, is that it subsumes a number of different competencies bundled within it. Things like being achievement-oriented, being self-confident, being optimistic, being a change catalyst, developing teams, being a servant leader. These are all embedded within the emotional intelligence model, along, of course, with empathy, which we hope is an attribute that every doctor has and is cultivated in their career. So emotional intelligence is a wonderful, if you will, grab bag compilation of leadership competencies, all of which are very important.
As chief of education at one of the world's most renowned health systems, what do you see as the most pressing changes that need to occur as we educate future physicians?
Yeah, it's a very dynamic world. And of course, there are technical things and there are human things. The technical things, of course, involved artificial intelligence. And what is it, as in every sector of society, what is its impact on the acquisition of knowledge by learners? We talk about de-skilling or unskilling. If one depends on AI solely, one can never develop the intrinsic skills that one needs to be a professional, whether it's a doctor, an engineer, a lawyer, a professor, a news anchor. All of these are relevant. The human dimensions that are tremendous are, as I said, healthcare is a team sport. We are not heroic lone healers. We are members of teams, and cultivating those skills as a team player, particularly in the world where there's consolidation of healthcare into larger and larger organizations, becomes very important. Again, as I said, these are not competencies that are routinely taught and may not be ideally modeled in traditional curricula. So they really should be called out and underscored in training and teaching.
I'm glad you brought up AI. It has quickly become front and center in all aspects of society, and especially in healthcare right now. How concerned are you about, what role it will take in leadership and how it will impact what our future leaders will actually be doing?
Well, AI is a powerful force, as we all understand. And as with every new technology in healthcare, we need to embrace it and understand its strengths and its shortcomings. I liken it hundreds of years ago to the invention of the stethoscope, right? That was a new technology at its time. And one needs to lean into that, master, how to listen to the chest and the heart sounds and so on with a stethoscope. And in the same way, and certainly this certainly underscores our own philosophy in our own training programs in the Lerner College, again, of Medicine. We are teaching our medical students to, on the one hand, master prompts and the acquisition of information through AI, but at the same time, cultivating sort of their circumspection about potential inaccuracies and hallucinations and the shortcomings. So they need to understand it, how to use it, how to mobilize it, and understand what its limitations may be. So they're not slaves to artificial intelligence. They have an independent knowledge base.
What core lessons could medical students start applying now, especially regarding leading change, fostering teamwork, and navigating complex healthcare environments? What would you like to see them do?
Well, I think the first order of business there is, going to medical school is a very busy proposition. There's a lot of things to learn, and every patient wants their doctor appropriately to be a master of physiology and pharmacology and clinical medicine. There's a lot to do. At the same time, I think it's increasingly important, as we've been discussing, that these other skills, team building, emotional intelligence, change management, are also important skills to learn. And so my response to that question would be that medical students, my hope would be intentional about learning these other skills, just as they are very intentional about learning the basics of becoming a physician.
What emerging trends do you see, or do you believe will be the most, or will most shape the practice of medicine in the next decade? Put your fortune teller hat on, right, if you will. What do you see? What do you see coming?
Well, the crystal ball has artificial intelligence all over it, right? And as I suggested before, it is very dynamic, changing quite rapidly, and also changing the way we think about learning and information available to us. The good news is that artificial intelligence will, when accurate, help us navigate a burgeoning volume of new knowledge. The half-life of medical information these days is estimated to be less than 73 days. There's so much proliferation of new information, research, and practice that it's very difficult to absorb that. Artificial intelligence can clearly help in that regard, and it's welcome in that regard. But at the same time, one needs to be circumspect about the shortcomings and flaws. We can't have doctors operating on hallucinating material, right? So that's the huge challenge. And again, it's a matter of embracing AI and leaning into it to understand it fully and to help craft how we use it. That's a huge, huge trend.
I appreciated your slide that showed that some of these skill sets, if you will, can be learned technology. Do you think that's something AI can actually help future leaders do, especially those who may not think that they have the wherewithal to become a leader?
I do. I think that AI is a complement to human interaction, right? I do not think it's a substitute for human interaction. However good your chatbot, it can never be as good as a human coach, for example. And so I think that AI is going to play a role in developing skills, whether it's clinical skills, scientific skills, leadership skills. But my view is that it should not be the sole source of such information. It needs to be done in tandem with a human dimension, particularly in a field like medicine, which is so human anchored, right? It is the ultimate human anchored profession.
How do you see it, though? Because we know it's already part of it, but how do you see it reshaping medical education?
Well, increasingly our students everywhere, college students, medical students, are using AI. There are a number of online instruments that help acquire and synthesize information. ChatGPT has been shown to be able to pass various certifying exams in medicine by itself. And so it clearly is a powerful force. And yet, as I said, we don't want slavish dependence on ChatGPT to result in de-skilling or never skilling doctors. We have to learn the material and then use ChatGPT as a trusted advisor and colleague, not as a substitute for judgment or knowledge. That's how I see the synthesis evolving.
I can tell from a layman's standpoint and from what I'm hearing out on the street that a lot of people are very concerned about AI becoming the diagnosing services. What's your take on that, and what's your advice? Obviously, to your point, medical students still have to learn the basics, but do you see it going to that? Because we know with a quantum computer at Cleveland Clinic, all the information that is going in there, that AI will eventually have that capability to an extent. But what's your take on that?
Well, there's no doubt that, again, as you point out, it's a powerful complement to human knowledge, right? And I do think that the power of AI will be, in my view, one of making access to the best information more democratized. And in other words, it will make it more widely available to doctors and nurses and allied health providers nationally. As I pointed out, one of our challenges is the unevenness of access to care in the United States. And so this could be a mechanism to level the playing field. But at the same time, it will never be, in my view, as good as it gets. It will never be a substitute for the nuances of human interaction and decision-making, values-based decision-making that is intrinsic to the doctor-patient relationship. It's always based on values and preferences, and a physician's obligation is to provide the spectrum of options to a patient, and the patient's opportunity is to pick which of those are most favored based on their personal philosophy and their personal goals. And that's what the physician-patient relationship is at its end. I'm somewhat dubious to think that AI will ever quite replace that. There are components and elements of medicine which will be powerful complements in imaging and in recognition of pathology images and so on, and it's already made inroads there. But I think the inroads into the value-based human connection of medicine is further afield. Yeah.
Let's move on. Can you talk about translational research and why it's considered central to improving patient care?
Well, translational research is critical. It is, as you know, it is the bridge between basic research and application of research. So if we think of the recent coronavirus, right, the basic research was developing mRNA technology that could produce these powerful vaccines. The translational development had to do with how do we make this available, make it useful, demonstrate its efficacy, what some people call implementation science. So translational science is critically important, as is basic science, right? Translational science without basic science is a vacuum. Basic science without translational science is a vacuum. And so we need both together to bring the greatest insights about science to the bedside. And translational research is the mechanism by which it brings those basic insights into clinical practice to the betterment of humankind.
Your presentation, you touched on a huge issue facing our healthcare providers, burnout remaining a significant concern across medicine. What's your advice to students? What habits do you think they should start working on or cultivating now to help them when they start dealing with those issues?
Yes, burnout is a very prevalent phenomenon in healthcare, and there are things that one can do individually, and then there are things that institutions can do. Certainly on the individual side, preserving your passion for things outside of medicine, whether it's art, spirituality. I'm an avid fly fisherman, a runner. Whatever it is that gives you joy needs to be preserved in the face of an otherwise very busy career. And so my advice to medical students is not to abandon those things, thinking that that's going to come back at some later time in one's life. You've got to keep that ember burning. From the institutional side, I think that, contributors to burnout include sort of the workaday challenges, for example, of often the electronic medical record, which is on the one hand a fantastic resource, but on the other hand, creates burdens and repetitive energy. And here too, artificial intelligence is making inroads. We at my institution now use artificial intelligence in developing clinical notes, right? And it has to be read and reviewed for accuracy. But in my experience of using this technology, it's pretty good. And it certainly can be a huge time saver. So that institutions leaning into this and embracing technologies that will unburden the process, the sort of grinding down process of administrative burdens that are not tied to the physician-patient relationship is another thing that can be done. Paying attention to burnout, having institutional programs that acknowledge it and help people navigate through burnout. These are very important antidotes to burnout, but it's a very real phenomenon.
Looking ahead, what do you think will be the biggest challenges and opportunities, if you will, for young physicians entering practice over the next decade?
Well, it is, as I'm sure has always been the case in medicine, it is a hugely exciting time in healthcare. Many of the trends that we've talked about, the evolution of artificial intelligence and the impact it will have on all disciplines, as well as, again, these human dimensions, the idea of acknowledging the importance of leadership and emotional intelligence. These are somewhat novel ideas in the curriculum of healthcare. And so the opportunity to integrate all of that together while preserving the core competencies of understanding anatomy and physiology and biochemistry and clinical practice. And these are just incredibly exciting things. And, our challenge as medical educators is to weave those themes all together in a holistic way to continue to produce caring doctors that are informed by technology, but not slaves to it.
I'm going to go out on a limb here, though, because we know that the state of healthcare currently is a bit precarious. And I know a lot of people are thinking twice about entering into medical school. What's your advice to the younger person who may be thinking, what do I really want to do? Do I go into medical school or do I pursue a different avenue?
Well, there are so many ways in life to make important contributions. Medicine is, of course, not the only one. But, even on difficult days, I take incredible solace in the idea that not a day goes by when I don't have the privilege of being able to impact someone's life, hopefully in a helpful way. I often think of the quote from Teddy Roosevelt that the greatest prize life has to offer is the opportunity to work hard at work worth doing. And while medicine is not the only work worth doing, it is clearly work worth doing. And so I would encourage students that are entertaining careers in medicine, if they have a passion for it and they have grit and persistence, because it requires that, I would go for it. Every day I would do it again in a heartbeat.
Dr. Stoller, such incredible insight. Thank you so much for your time. And thank you all for the questions. I'm going to hand it back over to Dr. Langell.
Thank you for joining us for Vitals. We look forward to seeing you for next month's presentation. Visit neomed.edu for more information.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.